Welcome and thank you for standing by. At this time, all participants are in listen-only mode. During the question and answer session, press star followed by the number 1. Today's conference is being recorded. If you have any objections, you may disconnect at this time. I'd now like to introduce Karen Francis. You may begin.
Thank you, and good afternoon, everyone, and welcome to the second webinar for the 2016 Rural Behavioral Health Webinar Series. My name is Karen Francis, and I'm a principal researcher at the American Institute for Research and the lead for the Rural Behavioral Health Initiative, along with my colleague Joyce Sabian from the Mental Health Promotion Branch at SAMHSA. This webinar series is supported by Mental Health Promotion Branch in collaboration with the American Institute for Research and Pharma Solutions. Thank you for joining us this afternoon. We're looking forward to a lively and engaging conversation about developing partnerships between juvenile justice and schools and providing mental health services in rural communities. For today's webinar are Grace Calisor. Grace serves as the Chief Bureau of Children and Family, Ohio Department of Mental Health and Addiction Services, and also as the Principal Investigator for the Safe Schools Healthy Students Initiative in Ohio. We also have Judge Stephen Bird from the Williams County, Ohio Juvenile and Probate Court, Jeff Spears, External Grant Administrator from the Ohio Department of Youth Services, and Ron Reiter, Schools Healthy Students Project Director, Williams County, Ohio. So during our webinar today, we will learn how rural communities can support the development of partnerships between juvenile justice, mental health, and schools to address the mental health needs of children and youth. We will also examine the key roles of state and community agencies in developing effective partnerships, explore effective strategies for the implementation of comprehensive and coordinated mental health services in rural communities, and learn about available resources to facilitate effective partnerships between juvenile justice, mental health, and schools to provide services and support. Now, at the end of the webinar, we will invite you to ask questions of our presenters by using one of two methods. You can either type your questions into the participant chat box that is located on the right-hand side of your computer screen, or you can ask a question when we open the phone line. We will respond to as many questions as time permits today. Please also note that this webinar, both the PowerPoint as well as the audio, will be posted on the Rural Behavioral Health web portal in about 3 weeks from now. Also, at the end of the webinar, I will provide you with the link for the Rural Behavioral Health webinar portal. Just a small reminder, we ask that you mute your phones during the presentation so as to avoid any background noise as the presentation is given. Also, please do not put your phones on hold, as we will be able to hear any background music or messages that are recorded on your phone system. So further delay, let us start with a few polling questions. We want to know about who our participants are joining us today on the call and where in the country are you from. So in what region of the U.S. is your community located? Please take a few minutes just to select your response. The Northeast, Atlantic, Midwest, South, Southeast, Northeast, the mountains, Southwest, Alaska, and Hawaii, or any other territories. Please just take a few minutes to respond. These responses to get tallied here. We have participants representing the Northeast, Mid-Atlantic, the Midwest, the South, Southeast, the West, Northwest, and Mountain Time, the Southwest. There's some folks that told us no answer. No, that one. So thank you so much for joining us today. Our second polling question: what is your role in your program and community? We'd like, to hear from you. So what will you play in your rural community and agency? That of management and administration? Are you a clinician or service provider? Family youth, community provider, federal, state, local policymaker, faith-based advocate, your community coalition representative, or you serve some other role in your community? Just a few minutes to ask you to respond to that. As we tally up this response here, then again, we have a number of folks here who play the role of management or administration in their communities, non-clinician service providers. We have even youth and family members on the line with us this afternoon. Welcome to you all, a special welcome to you all. We have community-based providers, as well as some state, federal, and local policymakers, some faith-based advocacy and community coalition members. So again, great pleasure really to turn this webinar over to our first presenter, Grace Calisoa. Grace will bring us warnings from the great state of Ohio. So Grace, go ahead.
Thank you, Dr. Francis. Ohio is very pleased to be presenting a small part of our work from the Safe School Health Student Initiative. So thank you for this opportunity in Ohio. We're bringing you a partnership, how effective it is in Ohio. Prior to our Safe School journey that started with just a single step, we have gone a bit distance. Prior to that, our rural communities needed better access to services, a system of school and community partnerships to support substance use, mental health, and violence prevention needs of students and families. Or is in a unique position to expand our strategic prevention framework in rural schools, districts, and communities to assess their prevention needs, build their prevention capacity, develop strategic plans, implement effective community prevention programs, policies, practices, and evaluate the outcomes. The Ohio Department of Mental Health and Addiction Services and the Ohio Department of Education have the resources and partners in place to support the community's social, emotional, and behavioral health needs. But what needed to be done with communities to identify partners, needs, plan processes for utilizing state and local resources to develop safe and healthier families, schools, and communities. An opportunity presented itself when Ohio Department of Mental Health and Addiction Services was awarded nearly $9 million from SEMSA to implement the Safe Schools Health to Students Initiative 2014 to 2017. We're in the third year of our grant. And the goal of our grant was to engage youth, families, schools, and community stakeholders in building local and statewide capacity to mitigate behavioral health problems in children, youth from preschool to grade 12. Ohio School Health to Student Initiative is a partnership with Ohio Department of Education, Ohio Department of Mental Health and Addiction Services, along with 3 Ohio's local educational agencies in our eastern, southwestern, and southwestern parts of the state. And our counties include Harrison, Greene, and Wake counties. They're fortunate to have Two dynamic leads on this initiative, Jason from Department of Education and James Trevino from Ohio Department of Health and Addiction Services. The 4-hour safe school initiative is developing children's social and emotional skills, promoting positive school climate, reducing school violence, increasing positive behavior choices, and increasing awareness and access to mental health services in Ohio schools. And communities promote healthy social and emotional development to help families build schools and healthy community environments through partnerships. And that partnership you will hear about today. The implementation of our activities started when we formed our state management team that is officially known as Ohio Shelter Schools and Communities Resource Team. I mean, with our Project Aware and School Climate grants, we have a dynamic and active statement team with multiple state system partners. Focus of our state management team is to develop positive school climate, reduce school violence, increase positive behavior, choice, and increase awareness and access to mental health services in our schools in supporting our communities. The mission of our state management team is to make sure that all Ohio children and families will be socially, emotionally, and behaviorally resilient and productive citizens. We adhere to our mission to help local communities collaborate to improve the health and well-being and educational needs of our children and families in Ohio. We are experiencing dynamic changes, and we're seeing changes emerge through our structure and robust early childhood mental health standards and support that we provide to the grantees, identifying with them mental health boards, agencies, community agencies, fund sources, rural communities. And we have a strong and structured family and youth involvement in our SMT and also in the communities as well. And we created and support the communities in community partnership and in developing strong community partnership that will be discussed today. So we are very pleased once again that you have given us this opportunity, and now I turn it over to George Berg.
Great, thank you, Grace. Very excited really to be able to share with you some of the work we've been doing here in Williams County. We are a small county, about 39,000 people, and located in the corner of Ohio. I've been juvenile court judge for approximately 20 years now, and I've discovered a lot of things over the years. Often I go to conferences, I learn about best practices, I learn about promising practices, I see what's going on across the country, and I'm back to my county and I'm frustrated because our resources financially are quite limited. We don't have a university in our county to provide us graduate students who we call upon for free assistance. And many of the resources that are available to more urban communities often don't exist here, even in terms of service providers and the quantity and quality of service that's available. So frustration over the years, but I always come home and I think, how to figure out a way to accomplish services are achieving in a way that works with a community like Williams County. It was really years ago when we began looking closely at the kind of issues we're dealing with here in Williams County. In 2011, I had the Reclaiming Futures Conference in Chicago, and from that conference convinced that we need a different way to think about the processes that we use. Juvenile court cases are often not what they appear to be when they come into the courtroom. It didn't long for me to realize that it's like a very simple matter, a delinquency charge, perhaps a theft offense. To unpack the case, we discovered that into the presenting offense, there were other issues going on, often issues of substance abuse and, unfortunately, from time mental health issues for the juvenile and issues that were contributing to the behaviors that were bringing the kids to court. It really, on occasion, was like opening Pandora's box. Probably 8 of our cases are sort of typical juvenile delinquency cases. The kinds of kids typically that get them in trouble, they learn experience, they exceed their probation, and they go out and they don't reoffend. The cases that really trouble us are the ones that continue to come back, or the ones that first present in court are so complicated and often far mental cases in treatment rather than behavioral problems in the traditional delinquency sense. Again, to address these issues locally, my probation staff and I and other professionals who work with our court begin to solve some questions about why do these kids come to court? What actually brings them here? Often it's their behavior from an incident at school, or as I said, a simple theft, offense, underage consumption. Number of delinquency charges might be the presenting issue, but like that, often were behavior problems, oppositional defiance disorder, a range of things that typically present, and then in some cases, much more complicated problems like attachment disorder. These kids who come in occasionally that are diagnosed with borderline personality disorder and mental health issues. And the family systems often what we would hope they would be. We did times that the parents raising the child has their mental health issues that have often not been identified, certainly not addressed. And so to really help that child's behavior improve and change, we've been involved in much broader treatment processes. After that conference in 2011, we came back and working with a friend of mine, Corey Davalier, who at that time served on the Ohio Supreme Court Committee on Mental Health in the Courts, and happened to live here in Northwest Ohio and have experience with mental health issues in his own life, to help put together a think tank called our people community, including our school psychologists, representatives from our mental health providers, other juvenile justice professionals, probation officers, and myself, educators, school administrators, to process and collaborate and explore what kinds of things need to change in order to make this system work better. Now, the ability to do that kind of collaboration didn't start in 2011. And to get people to come to the table and to whether productively, it really takes a long time, a process of nurturing those relationships. I was here in 1997 as a juvenile court, and when I came, those relationships were already in place. Prior to me, Mary Rigdon had done an excellent job of building those relationships, and we worked hard over to maintain them. So I regularly meet with school administrators, superintendents. We hold programs and invite teachers and school counselors. Regularly with chiefs of police. I have mental health providers who work with our court, substance abuse treatment folks that work with our court. And by keeping those lines of communication open, we've been able to build and foster a real long collaborative relationship. I take credit for that. I'm really grateful that those important were in place when I came. But I see the advantage of being a judge who can get people to come to the table. And inviting people to come and participate in looking at problems and trying to craft a better way of doing business. Opportunity here. How do we do that? Well, First, we talked to one and to those that came before the court, in particular school administrators with cases, delinquency cases arising out of school settings. And we found often they were very frustrated that these kids, by the time they were 13 or 14, are presenting in juvenile court. But the problems really started before that, sometimes even in kindergarten and first grade. That tended to increasingly deteriorate over the years to the point where, despite the best efforts of the school, they became very, very difficult to work with, very frustrating to school officials. And ultimately, they went to court, hoping that the court can solve all these problems. Of course, we have magic solutions, but realize as we unpack those cases, there's some common threads here. And among them, with our most complicated cases, the realization that for a time the school had identified this child having problems, and we have services in our community that could address problems, but there's no connection made there. There wasn't a system in place for linking those children and families with needs to the treatment services in the county. If we're going to explore this, we ought to talk to the people who are on the front lines. Over and over, we would hear that kindergarten teachers, for instance, have a really good batting average when it comes to identifying kids who will eventually become problem kids and wind up in juvenile court. And we like that fact they were such good predictors, but we realized we should talk to these teachers and find out what really helped them. Why is it they're so good at spotting potential problems? So we started reviewing kindergarten, first grade teachers, and got a lot of really valuable input. But one thing became very clear was a sense that there was something that wasn't right with the child or their family. They felt they were not prepared and weren't trained to understand the mental health issues and the family function issues that may be involved. And they were reluctant to label a child as a problem at such an early age, and yet they seemed to have ability to sense that there was a need there. I realized that in early intervention, we need to provide some education and training to teach in the area of mental health. And we've been developing our program. By that, different models and how courts were handling these issues by looking at the possibility and the effectiveness of early intervention and identification of problems, working with schools, working with the teachers, and working with other mental health professionals. We tried carefully to what each of these groups had to say, and then, stroke of genius, we decided to talk to some of the kids we were working with, and not only find out what the problems were, but to ask the children and their families what would have helped you if we would have provided it at an earlier state. The end of all that process was our think tank came up with the LINC for linking individuals with needs to the community. The idea being teachers and other school pretend they grade area to help identify problems at the earliest possible stages, helping them understand mental health issues, providing them some education. We did a county training called Mental Health 101, put on a school psychologist and Cavalier, who went to each of the schools and did some basic training in understanding mental health issues. We know that if we provide intervention to these kids when they're lower risk, we can redirect the course, help those kids and their families learn. Resources are available to address their issues, to learn better coping skills, and just reduce the risks of future delinquent behavior. And importantly, schools provide a great opportunity to provide a linkage to the services that do exist in our community. Of all that was we concluded that what we were talking about here wasn't a simple task, and it really was going to require sort of system-wide change, a different approach to the way we traditionally do things. Than the schools cope with problems until they were exhausted, and then turning them over to the court, hoping the court would be able to solve the problem at that point. We need a real partnership where the court would support the early intervention efforts with that perhaps kids would never wind up coming into the juvenile court. And we were committed to make resources available to help that happen. Schools needed to understand mental health issues and needed to have their ability to refer issues for assessment and potential treatment to the mental health providers in our community. Really, by restructuring our entire system, we hope to achieve a much greater outcome. The only was figuring out how to fund all of this, and that our Safe Schools Healthy Students became really valuable to us because it gave us an opportunity to move this whole process forward with respect to the mental issues into the schools. You'll hear more about that later in the presentation. There were some when you set out to change how systems work. And really, the whole issue of mental health presents some real challenges, especially when we're working with children and families. Stigma and misinformation, and because stigma, teachers were reluctant to identify kids as having needs. Often families were reluctant to accept help. So, dealing with information that surrounds the mental issues, helping us understand that it's not fault, so to speak, but there's a lot that we can do to assist them, to teach them skills, to help them understand what they're dealing with, and the end being that these kids from following a track into juvenile justice. Teachers, of course, who are ill-equipped to handle mental health issues or even to recognize the symptoms accurately, need professionals available to them in the schools. And our thinking was getting social workers in the schools to help screen those cases and do case management, make referrals to mental health providers. And our juvenile justice systems were experiencing real overwhelming responsibilities when these cases would arrive on our doorstep, blown. Kids were adolescents already and had very complex coping mechanisms developed, which require a great deal of treatment and very expensive treatment, which is taxing our systems. So thanks to Safe Schools Healthy Students, we've been able to make some progress there, and the Ohio Department of Youth Services has been a great help to us through Reclaim Ohio program, and we encouraged courts find community solutions, but purpose with funding to help us do that. And so in Williams County, we've adopted the Reclaim Futures model for our court. It's a comprehensive process, beginning with screening every child that comes before the court to identify potential issues, not be obvious from the charge that brings them here. It allows then to, where appropriate, do further assessment, refer those kids to treatment, and build that into their probation process. It's really a continuum of care that allows us to work more effectively with kids and families to see that they get treatment they need, and then help them engage in the community so the community takes ownership of our kids and to build a environment for the kids to re-enter the community and become part of that process. But it requires us to take ownership of these problems and to reduce the negative impact of court intervention. So, two sides to this approach. First, early intervention, primarily happening through the schools. Then a better approach once the kids arrive in court from the court side of things. Researchers, I think, is going to give us some great opportunities. We're currently working with 2 counties in our region to adopt these policies and these approaches on a regional basis. That we took advantage of the opportunity to for certification by the Ohio Supreme Court as a family intervention court or alternative docket problem-solving court. This is some stability under the Ohio Supreme Court rules to work with select families who show in at least 2 areas: substance abuse, mental health, and family issues. And so some families can be offered an opportunity to come outside the traditional court docket and work with family intervention court docket in a treatment-focused court, similar to drug court process, recognizing that seldom are these issues isolated. In order to be truly effective, we are able to address all of those issues with the entire family. It's through a treatment team process that meets weekly and creates a treatment plan for the family, and the court monitors those families with weekly review hearings during the first phase, and then bi-weekly during phase 2, and once every week during phase 3, and so forth. To work with the family as a unit, to and provide services, and through them of incentives and sanctions to help them on track and have a better outcome. It was really about putting all the pieces together. The program, as it turned out, helped us provide a lot of hope for these kids by identifying at the earliest possible stage when we're beginning to go off track or families were struggling with issues, and to provide appropriate interventions. Health providers, the community, the schools, and the courts work together to provide a positive for kids and get the services to the people who need them in the most effective way. And then Claiming Futures and Family Intervention Court on the court helps the court do a better job of seeing, understanding what the problems really are, and accessing and delivering evidence-based interventions that allow us to have the most positive outcomes. Of course, we have to alone. Our partners at the Department of Youth Services have been critical to giving this opportunity. I'm looking forward to you hearing from Jeff Sears, who's been helpful to us, and then Ron Reiteicher, who is in fact directing our Safe Schools, Healthy Students program, has done a fantastic job of this process together and helping to make it a reality. Your time. I hope you enjoy the rest of the presentation.
Thank you so much, Judge Bird. And as you said, we'll turn the webinar now over to Jeff Sears from Ohio Department of Youth Services. So, Jeff, do you want us to advance your slides, or do you want to advance your slides?
Fine with advancing them.
All righty.
Thank you.
Okay, it's all yours.
Well, first of all, thank you very much for this opportunity. We greatly appreciate it here at the Department of Youth Services, and thank you, Judge Bird, for your kind words, and really put into context the complexities that we see that our juvenile courts are dealing with. The Department of Youth Services is the state agency juvenile justice system, a cabinet level position with our director of the cabinet level position in state government. The Department of Youth Services operates 3 juvenile correctional facilities and also 5 regional parole offices. And then we fund, but do not operate, 12 local community corrections facilities and where that are on suspended commitments to the department may be placed. And also we fund a whole host of initiatives in the community to try to assist them to identify and the needs of their youth and families, and then also to just what is the best services for their community. The overview I'm going to kind of give you is really just the role of the state agency in trying to support the community to address these behavioral health needs that they're seeing. And I must say, first of all, it just could not be done without the excellent partnership we've had ongoing with our Ohio Department of Mental Health and Addiction Services, and also our juvenile courts, and then our locally operated alcohol, drug addiction, and mental health services boards. For context, the first thing I'm going to quickly discuss is kind of the background here in Ohio, a little bit of actually having trouble, pardon me, my slide did go, I apologize. I want to talk about the foundation and the history, first of all, so you have some context of some of the challenges that we have to overcome. First of all, Ohio is a home rule state. A home rule state is a state in which there's been an amendment to the state constitution that grants cities and municipalities and or counties the ability to pass laws and to govern themselves as they see fit, as long as they obey the state and federal constitution. This includes local operations of 88 juvenile courts and around 52 alcohol, drug addiction, and mental health services boards. We also have in our foundation is a funding mechanism that was created in 1994 called Reclaim Ohio. Reclaim, which stands for the Reasoned and Equitable Community and Local Alternatives to the Incarceration of Minors. It's a funding initiative which encourages juvenile courts to develop or purchase a range of community-based options to meet the needs of each juvenile offender or youth at risk of offending. So we did have in place at least a mechanism so that juvenile courts could identify their needs and to come up with what are local solutions. The next piece of our foundation, which is very important, is in 2008, we entered into a settlement agreement as the result of a very large lawsuit that was centered around conditions of confinement. Lawsuit ended up bringing about really a long-term investment in Ohio's youth by infusing new resources into DYS operations, including funding for evidence-based community programs for low-risk and moderate-risk offenders. And the last piece of our history that we have is what we call the Behavioral Health Juvenile Justice Initiative. It's actually quite old. It began over 15 years ago when Ohio's juvenile court judges met with representatives from the Department of Mental Health and us and the Department of Youth Services to discuss their concerns regarding the mental health and substance use problems they were seeing in the juvenile justice population locally. Just expressed to us that they not only lacked resources and expertise to identify, assess, and serve these youth, but there were few alternative programs in the community really in place of, in lieu of just placing them in detention. So the Behavioral Health Initiative, then, thing that we've now used in partnership with Mental Health and Addiction Services, which assists us with funding, to address the mental health and substance use needs of court-involved youth. also really work from the basis in our development of services in the community and our partnerships with our courts and other agencies is some guiding principles. First of all, we acknowledge that we're dealing with multi-system youth, and we must collaborate with the other systems, with our mental health and drug addiction boards, our state agency of Job and Family Services, the Department of Education, community providers, local colleges and universities, and our juvenile courts and our locally operated detention centers. There's 38 detention centers in Ohio that the juvenile courts will use, and they're all locally operated. Is that one of our principles is that everything really needs to begin with screening and assessing. It's imperative. What for screening for across Ohio are not only the mental health and substance use needs, but also the criminogenic risk and needs. A leading principle is the intensity or the dosage of a service should really match the risk level. We've had a lot of research done by the University of Cincinnati under Dr. Ed Latessa in regards to risk and need principles. And we have found is that low and moderate risk youth, and that's risk to reoffend, do much better in community-based programs, while high-risk youth do much better in residential care. And this builds upon the risk principle, which proposes that the intensity of service be matched to this level of the offender, and the need principle, which focuses on targeting appropriate criminogenic factors such as thoughts and attitudes, antisocial peer associations, poor parental monitoring and supervision, identification with antisocial role models, poor social skills, and substance use. We also operate under the principle that the state should incentivize the use of evidence-based programs and practices, and we really push the use of those that are listed on SAMHSA's National Registry of Evidence-Based Programs and Practices and the Justice Department's crimesolutions.gov. It's a great resource to use to identify some potential solutions for local problems. Guiding principles also include in many of our initiatives that there is an appropriate access to Medicaid. This, many years ago, was not the norm for the juvenile justice system to be involved in, but over time we realized that it's really imperative to the financial stability of a program to have Medicaid access when appropriate. And so the department has promoted really the core elements and principles of both the Robert Wood Johnson and the Annie E. Casey Foundations. RWJ's Reclaiming Futures Initiative, which Judge Byrd and his two other contiguous counties are involved with, is a great resource and direction for many communities to take, and the department has assisted with families engaging with RWJ and moving forward and becoming a Reclaiming Future site. And then the Annie E. Casey Foundation's Juvenile Detentions Alternative Initiative is something we've really has caught fire here in Ohio over the last few years, and has really promoted some better practices in detention, such as screening and assessing, and also the development of services in the community to divert youth from detention. made some pretty significant investments in Ohio, and I just want to share them with you because they've been things that have really paid some dividends for us. And if you are at a place where you're looking around and trying to decide maybe what you should invest in, I just wanted to share with you these are some of the ones that we've seen to be the most beneficial. First of all, we promoted the use of the Ohio Youth Assessment System with the juvenile courts. The Youth Assessment System, which we call the OYAS, was actually developed by the Center for Criminal Justice Research at the University of Cincinnati. It's predictive of future offending, and it has domains or areas that the assessment looks at under family juvenile justice history, family living arrangement, peer and social supports, education and employment, substance use, mental health disorders, personalities, pro-social skills, and values, beliefs, and attitudes. For many initiatives, we actually require the use of the OYAS, so courts will at least have a baseline to measure the criminogenic risk need. The second thing that we've invested in significantly has been the MAISY-2, and that was MAISY-WARE. The MAISY-2, which is the Massachusetts Youth Screening Instrument, is a self-reporting inventory of 52 questions, and it's been designed to assist juvenile justice facilities in identifying to 17-year-old youth who may have special mental health needs. And we've promoted the use of that across the 38 detention centers in the state. So we believe it's a good foundation, and it has been validated on the juvenile justice population. The piece, which was mentioned earlier by the judge, is our Reclaim Ohio. Reclaim Ohio has expanded significantly over the last couple of years to help fund these local initiatives that juvenile courts are starting to develop to address these complex needs, such as what Judge Byrd discussed. Under Reclaim Ohio umbrella of funding, the department now allocates about $82 million annually to local communities to identify and to develop their solutions. That money is broken down and actually dispersed in many different forms. We have the original Reclaim grant, which is right around $30 million. We have which is in which each county submits a plan to the department on how they would like to spend the money. Then we have a youth services grant, which is based upon population, around $16 million. And then we have a group of initiatives. We have a targeted reclaim, competitive reclaim, the behavioral health initiative, and the detention alternatives. We're spending another $10 million to provide very targeted and focused interventions locally. And another one of our investments has been the use of wraparound. The department has partnered with mental health and addiction services for many years on wraparound, and is currently involved in an initiative with the Department of Mental Addiction Services, we call the Engage Initiative, funded out of Samson, to promote high-fidelity wraparound across Ohio. And in collaborating and partnering with each other, we actually require some applicants for our funding to participate in the Department of Mental Health and Addiction Services Engage Initiative. We've done that on several occasions, so they have a more comprehensive means to take the to look at what the needs are of the family and to make sure that the family voice and choice are addressed. Investments include, as I said, the expanded reclaim programs, which I will tell you over the last about 20 months, we have funded 74 additional community programs, and many of which to address the behavioral health needs of youth. Another investment we've made, and it's very important, is we have contracted with university partners for quality assurance activities. Case and Reserve University in Cleveland is one of Ohio's coordinating centers of excellence, which receives funding from the Department of Mental Health and Addiction Services. Center of Excellence, it was established by mental health to promote the implementation of evidence-based practices and clinical best practices that address critical needs of adults and children affected by serious emotional disturbances and mental illness. To this presentation, I do want to touch on some of the rural EBPs, and they do work. But I think sometimes you have to be very creative in developing an evidence-based program in a rural community because of the expense that's involved. Communities under these last couple rounds of funding, we have been able in rural areas to fund multi-systemic therapy, integrated co-occurring treatment, intensive home-based treatment, and multidimensional treatment foster care. EBPs work very well by what we see as a way of doing this is to expand existing evidence-based program team from contiguous county in a community. That way you do not have the expense of an entire team. We've been able to promote the use of multi-systemic therapy in about 5 rural counties recently by just having the team hire an additional clinician within the county where the services are needed, the rural community, and have them trained and then work underneath that team. And that works very, very well. In the rural EBP, things that's helped this work for us is that they have used licensed clinicians and they have access to Medicaid. I know specifically to multi-systemic therapy, we have seen an offset of about 50% of the expense to Medicaid of the actual services by the clinician. Also seen as this best when services are delivered, in the school and in the home. We've really supported and preferred home-based and community-based interventions. We have also seen best results when we blend state, local, and federal dollars. And also, something that we've seen work well, and we've funded under the Detention Alternatives Initiative, is funding clinicians in detention to divert for treatment, and we've actually seen the ESPERT protocol, or the screening, brief intervention, and referral to treatment, used in detention in several places in the state effectively. With all these investments, our outcomes have been pretty good, though, this is something that's in a process of growth and is going to take many years to eventually be to the level we believe it needs to be. What we've seen with our outcomes as it's affected the state agency is that we had a decrease in commitments from about 1,579 youth in fiscal year 2009 to 478 youth in fiscal year 2016. And what we've been able to do is reinvest the savings. We've done that through a piece of legislation we refer to as House Bill 153, which the department actually is able to retain some of the savings that is achieved during a year due to reduced expenses in institutions, and the money is transferred to the division where I work, which is community and courts, to disperse it to communities under grant programs, and that's beneficial to us to have additional dollars to help build community programming. Also seen as outcomes, we've seen a significant decrease in out-of-home placement for juvenile courts and community partners, and they've reinvested the savings. In one rural community, the savings was so significant that they've been able to take their dollars and then the implementation of a county-wide use of the child and adolescent needs and strengths assessment for their schools and their behavioral health providers in their juvenile court and their family and children first councils. Outcomes are very important is to contract with the university partners to provide quality assurance activities that include monitoring the fidelity of the tools established by the model developer. What we've done is we will provide grants to rural communities such as to develop an MST team or an FFT team or to wrap around into the community. And we hire Case Western Reserve to go into the databases that have been developed by the developers to monitor the compliance of the programs that we're funding and ensure fidelity to the actual model. And that has been very, very helpful because you can quickly see when a project is starting to maybe veer off course a little bit, and you're able to quickly correct it. I really highly recommend kind of a behind-the-scenes monitoring of the actual programs that you're doing from a quality assurance and fidelity measure perspective. So what we've done on outcomes is we've conducted an ongoing longitudinal study of several initiatives, but in particular the Behavioral Health Juvenile Justice Initiative. We have now data results on about 3,500 youth that have been through the program since 2006. And we're very pleased with what we've seen. The youth in the Behavioral Health Juvenile Justice Initiatives, which in both urban and rural communities, very good, because youth typically have a co-occurring disorder of both mental illness and substance use. And what we have seen is that youth that complete their Behavioral Health Juvenile Justice Program usually has about a 56% reduction in out-of-home placement. We see that a significant improvement in attending school. Nearly 68% of all BHJJ youth were suspended and expelled from school in the year prior to their enrollment. But at termination from the Behavioral Health Project, 86% of youth were attending school from the most recent research study we had done. We see a significant decrease in trauma symptoms, problem severity, and increased level of functioning. Look at the 6 subscales of the trauma symptom checklist for children, and then we use the Ohio scales to monitor the problem severity and the level of functioning. The Behavioral Health Project, something we're very pleased with is that of the youth charged with a felony in the 12 months prior to intake, 74% did not receive a new felony charge in 12 months after termination. And of all the youth that participated in the program since 2006, 96% have not been placed in a DYS facility at any time after their enrollment. So we've done quite a bit to try to assist and work with our state and community partners to identify and develop additional resources to address the needs of youth and family with behavioral health issues. We still have some ongoing challenges, though, and I just wanted to bring to your attention because you may see these yourself, and they're to address very early on if possible. First of all is sometimes some evidence-based programs you see will place some strain on another system. Sometimes you'll see an additional number of placements in children's services. Not always, but sometimes you will, and I believe you need to be sensitive to that to make sure that you're not causing a problem for another system. Also, another challenge we've had is, Medicaid is not permissible in detention centers, even, during pre-adjudication or when you're trying to kind of determine the facts or what's going on with the child, and that becomes a challenge because, local detention centers, it can be quite an expense to assess all of the needs of a child, and then if a child also has some medical issues or medication issues, it also becomes very expensive. And then what we also see is there is really an inadequate number of clinicians in rural areas. We're really hoping to address that. Grace mentioned earlier some of the initiatives that's going on at the Department of Health and Addiction Services, and one of them is the SAMHSA state-funded youth treatment planning grant. It really focuses on the 32 rural, what we call the Appalachian counties, which are, their federal designation. And it's how do you develop the workforce within those communities so you can actually some of the evidence-based programs. So I just really wanted to give you a good overview of kind of where we're at in Ohio. Though we've had a lot of work done in the last couple of years, I think there's still a lot more work that needs to be done with the juvenile courts and the local communities to assist in addressing the behavioral health needs of this population. And with that, Ron, I'll move on to you and what you are doing with your project and addressing some of these issues.
Okay, Jeff, appreciate that, and just wanted to, as Jared started off his presentation talking a little bit about Williams County, I thought I would try to spend a little more time giving you an idea of Williams County and what it's like to live in Williams County just by giving you some demographic information. So I've highlighted up in the top left corner of the map Williams County, and it sits in the Great Black Swamp region. And long ago, Native Americans actually refused to live in the region because of the difficulty getting around. But the area consists of some of the most flat and fertile agricultural land in the entire United States. Williams County is also home of Spangler Candy, which is famous for manufacturing candy canes and the Dum Dum Sucker. So despite what you might think you'd smell in a rural area, it usually smells pretty darn good around here. You might have received one of the Dum Dum Suckers at a bank drive-thru, on a store counter, in an office, or even snagged one on a parade route because they're pretty prevalent around the United States. It's also the home of Ohio Art, which is the original maker of the Etch-a-Sketch. And it's also located, as mentioned before, in the northwest corner of the Buckeye State, which is a long route, Interstate 8090, also known as the Ohio Turnpike. Our communities are at the western end of the Turnpike, bordering Indiana to the west and Michigan to the north, situated between Chicago and Cleveland, which can be reached by a car in approximately 2.5 hours. Close proximity to Cleveland Cavs territory. By the way, they were the NBA champs, in case you weren't aware. and also close to the first place Cleveland Indians baseball team in the Central Division. We're also famous for the Toledo Mud Hens, made famous by Jamie Farr from MASH, and of course, the college of preference is Ohio State, and OHIO is a common greeting for anyone wearing clothing identifying themselves from Buckeye State. Williams County has a population of about 39,000, 36% considered urban and 64% rural. Communities consist of, as I mentioned, large farming communities and small businesses. It covers a land area of 422 square miles. Major cities closest to us are Toledo, about 50 miles away, Fort Wayne, 55 miles, Fort Wayne, Indiana, 55 miles, and then Detroit, Michigan, 75 miles from our location. So public schools in Williams County is 7, and the schools are supported by Northwest Ohio Educational Service Center that's located in Archbold, Ohio. Our enrollment for our students is a little over 6,000, and the population is approximately 88% white, 5% Hispanic, 3% 2 or more races, 2% Asian, and 0.5% African American, with less than 1% American and Alaskan and Native. The diverse school that we have out of our 7 public school districts is North Central, located in Pioneer, Ohio, and they serve 609 students, and they have approximately 10% minority population, which equates to 10 students, and so those are Hispanic. Minority enrollment in Williams County as an average is 7% of the student body, and again, majority is Hispanic, which is less than the Ohio State average of 27%. The median household income is approximately $43,000. Major employers in the region are auto-related, medical, education, and agriculturally related occupations. Poverty rate sits at 14.2%, with the free and reduced student population at county level of an average of 43%. So I'm trying to connect the dots between what Judge Byrd and Jeff were talking about. Williams County was granted a Safe Schools Healthy Student initiative in the fall of 2013. I was fortunate enough to join that effort approximately a year ago, in year 3 of the grant, and wanted to outline a few things that I think have happened in relationship to the Safe Schools Healthy Students grant since that time. The effort was to collaboratively network community agencies and institutions to ensure a continuity of care for children and youth struggling with mental, emotional, and behavioral needs. And vision included positioning social workers in the schools and providing professional development on issues related to the mental, the emotional, and the behavioral health of children and youth to school staff and community members involved with children and youth. As Judge Byrd had said before, there's definitely an education language and definitely a mental health language, and the two are not really talking very well together, both working very hard, but just not on the same page with the needs that our students have. For the initiative were to adopt evidence-based resources to improve the social, emotional, and behavioral health of our children with ages from 0 to 5. There was a particular concern that there was a lack of resources available to teachers and parents to support their children with social, emotional, and behavioral issues in and out of the classroom, and more likely the social and emotional readiness of children as they were preparing to enter kindergarten. Our second goal was to place care coordinators or social workers in the schools, with the end result to provide school-based mental health services to each one of the school campuses, eliminate barriers to access mental health care that was available in the communities. Although all 7 school districts expressed interest in the school-based mental health services, Montpelier School District was the only school district in Williams County with full school-based mental health services on campus at the initiation of the grant. We'll talk about that later. Then our third goal was to improve communication and increase involvement between parents and schools. And obviously, we wanted to increase parental involvement and to make their efforts both meaningful and also to incorporate their voice in decision-making as we went through this process. Our fourth goal is to prevent substance abuse and substance use and abuse among 6th through 12th grade students, and wanted to attack that by supporting existing prevention efforts and to create some youth-led initiatives to empower middle school and high school students to address the alcohol, tobacco, and other drug issues that was happening in their peer groups. Fifth, address bullying and other safety issues, and we believe that a youth-led activity could be both feasible and effective in addressing the issues of bullying in the schools through the efforts of Safe Schools and staff, and with input from a youth-led prevention team of professionals, including school counselors, Peer Making Peace, selected as an evidence-based practice there to assist with the effort. And the goal is to improve the social and emotional skills of elementary students and to improve our classroom climates. We identified the need to better understand discipline concerns that was coming out of our elementary classrooms. And in that effort, we developed a tracking tool for principals to log referrals to the office, and then that tracking system has been implemented in the schools across the county, and we're studying that to gain a better understanding of the behavior issues coming from that population. So in an effort to address the concerns, as Jeff had indicated, great efforts to evidence-based programs, and I thought I'd highlight the programs that we have implemented in Williams County, and just give you a little highlight of what has been accomplished with that. So evidence-based programs really provide us opportunities to programming that is tracked. Everybody in our area seems to work really hard, but we really lacked the evidence behind it. Really know that we were making a difference, and those space programs really got implemented with an eye on and a commitment to fidelity while being proven effective. Now are gathering data that really indicates how effective that is. So the first program I'd like to highlight is our PACS Good Behavior Game, and it was chosen to improve the social and emotional readiness for kindergarten students. And we were using our Ohio KRA, or our Kindergarten Readiness Assessment, that's administered to all of our kindergarten students within the first quarter of the school year. It was also implemented to, the PACS was also implemented to assist in reducing off-task behavior and to decrease disciplinary action in the elementary grades. And it has, and I've got a long history of being involved with education, and that is one effort that virtually by word of mouth from teachers and staff talking back and forth, seeing differences that program has made. It's had some dramatic impact in our elementary schools around the county. Care coordinators have been mentioned in the past, are school-based social workers that we placed in schools was using the Hot Springs, Arkansas model, guide our schools through an effective referral process to get earlier intervention and to also make solid referrals to our mental health agencies as deemed necessary by the school-based team. So the social workers are now in the schools and are part of the school-based team, and they assist parents from kindergarten through 12th grade navigating the mental health services that are available in the community. Not only helping them navigate it, but to get directly hooked up to those services and make sure that they're going along beside them as advocates, and also following up with them if there were reasons that they may not have been able to keep their appointments. And our schools have been really giving us some positive feedback about having someone tag along with the parents to get things done in between different meetings that they may have at the school level, and that had a major impact on moving along in a good direction for the students that they've identified. We also partnered with an additional initiative in the state of Ohio known as the Whole Child Matters, and that provides the similar kind of supports for parents of our preschool age children, which completed the continuum from preschool to grade 12, having the students supported as well as the families supported to hook them up with their agencies in our area. We did have a next evidence-based program that I'm happy to talk a little bit about as our school-based mental health counseling program. And as mentioned before, it existed in one of our 7 school districts as a collaborative effort between the juvenile courts and the local mental health agency entitled Family Services of Northwest Ohio. And we're extremely excited to begin expanding that service to all of our school districts in collaboration with the community hospitals of Williams County this fall. We have a potential, I think, to have a huge payback for our families, and really grateful to the hospital for this collaborative effort that they're willing to sustain, actually 100% independent of the initiative. So we've spent a lot of time working on that, and I think that we're going to be able to offer something to our families that just has not been available to this point. Another evidence-based program that has been implemented is the FAST program, or the Families and Schools Together. And it's an evidence-based program that improves family and school relationships, and it has increased parental participation, and we've done that in cooperation again with Family Services of Northwest Ohio. One that I didn't add to the list that I do want to mention is our youth mental health first aid. In an effort to try to bridge the gap between the educational world and the mental health world, we've offered consistent trainings throughout this last year with youth mental health first aid, and have trained over 100 school personnel and also community members in that program, and we're planning to continue to do that, and do believe that we're getting quite a few boots on the ground with different eyes to look at the student needs and what we've had before. We also have youth-led prevention. I mentioned peer making peace before. We have a program that's providing peer-led mediation services to schools. We also have adopted in 4 of our school districts the second step curriculum that focuses on social and emotional training. And it definitely targets students that may have not felt safe going to school, and also the potential to reduce physical fighting within our schools. Initiatives that we're focusing on is positive behavioral interventions and supports, PBIS. 5 of our school districts are going to be implementing that this fall, and have started planning with our state support team to address off-task behavior, discipline actions, and also overall school climate that exists in the school buildings. And finally, we've partnered with Recovery Services of Northwest Ohio, which is a local mental health agency, to provide opportunities to expand their services for the Too Good for Drugs curriculum that's in our schools. limitations to their budgets in the past hasn't allowed expansion or for the purchase of supplemental curriculum materials, and collaboration was formed to address the percentage of students that reported substance abuse in our student surveys. And then focus a little bit on what I consider our rural edge. I think Jeff pointed out real well, and Judge Bird pointed out real well, that sometimes the rural things doesn't always, we don't have the advantage of having a lot of different programs at our disposal. And often, you know, people look at me with dismay. I know other citizens that live around here look at us with dismay when we describe that we lived in a region that was once known for swampland. However, like any place, there are some positives and negatives to consider, and it's obvious that others consider rural living to be different. I think that's why you're tuned into this webinar, and I'm not knocking SAMHSA in any way, but I assume that's why they've got a webinar series dedicated to rural populations. I have to acknowledge that I believe we, the rural communities in Williams County, made strides at improving the continuum of care for families, implementing those evidence-based programs that I just spoke about. Really focused efforts in enriching relationships with people to improve the mental health of individuals and families. Opportunity to enrich those relationships, I believe, are part of the positive rural edge. Bird talked about the high level of collaboration that exists in our area. I don't think that's unique to a rural setting, but cooperatively, we're striving for a greater continuum of care for students, expanding those mental health services into the schools. And as we collect data and continue to offer preventative programming, our court system should be a benefactor. And as he mentioned, I think they're seeing some of those benefits from the programming that I just reviewed. Improving the overall school climate and earlier identification of those with mental health needs will lead to greater overall health of our communities. But the challenge of the rural living is living with limited resources and choices, and overcoming the lack of resources is most frequently overcome by the power of those relationships and working collaboratively with the resources that we have and blending things together. Prior to any efforts by Safe Schools, that cooperative atmosphere again did exist. There's no doubt that the level of cooperation between the mental health providers that we've been able to partner with is in a better place than it was even a year ago. And thankful for that relationship with juvenile justice, with the schools, and also with the local and state level and federal level to bring the programming to our communities. Also thankful for the new agency partnerships result from sitting down at the same table at our community management team meetings, discussing common issues and really realizing all the hard work that goes on by those team members to give the extra effort to make up for some of the lack of choices and to address the concerns that we have in the rural setting. So I think we all know nothing really changes or improves with a specific purpose, and I think the Safe Schools has kind of helped bring some of those things together in our community, and nothing changes without hard work. And we had a lot of hard work going on. We've just been able to expand upon that. So our data is really starting to come back to tell us that within 1 year, our collaborative efforts have reached 271 students. And I know it doesn't sound like earth-shattering numbers, but prior to the initiative, the numbers that were tracked indicated that we were serving 68. Data also tells us that 42 students received the assistance of a physician compared to 2 referrals that were made the previous year. Our data also tells us that there were and there are 112 students in need of additional mental health assistance, and again, that was wonderful data to have when we were looking at trying to partner to provide school-based mental health services. And at the same time, we realize there's a lot more work to do to make everyone in our communities healthy and productive, but the collaborative efforts that I mentioned, our community is a better place to live. So I want to thank SAMHSA, everyone behind the scenes to organize the webinar and highlight the work that's going on in Williams County and also the great state of Ohio. So thank you.
And Ron, thank you so much for that wonderful wrap-up, and, thank you also to Judge Byrd and to Jeff and to Grace for your presentation. So I'm looking at the time here, and we're just edging like with a minute left to do a lot of stuff. But I at least want to ask just two questions, ask if our presenters could quickly respond to those questions. So one of the first questions we got was, what screening tools are used in schools as part of the process for identifying children who are in need of services? Judge Byrd, I think that was part of your presentation.
Here at Juvenile Court, we're using the GAIN short screen. I'm not what the care coordinators are using. Ron, maybe you can answer that.
Yeah, our care coordinators have really been embedded in as part of the response to intervention teams. Really, their initial referrals are coming from the conversation around the table with the educators and with the family members to try to identify their needs, and then they move forward. There really hasn't been any specific screening tools that have been used for that. We are investigating, looking at trying to bring the expert assessment into the schools to give another data point to try to help identify some of those concerns at an earlier level.
Okay, thank you. And Grace, could you mention what other two counties are part of this Safe Schools Healthy Students Initiative?
Well, actually, mostly we leave that to the communities to decide what tool that is effective in the community. So we don't impose. We can make some suggestions and answer, but we don't impose specific tools.
Okay. And also, Grace, what other two counties are part of the Safe Schools Healthy Students Initiative in Ohio?
We have Harrison, which is on the east side of the state, and we have Greene County, which is on the south side of the state.
Excellent. And could somebody just say really quickly what, again, the LINC stands for, LINC?
Linking individuals with needs to the community.
Thank you. Thanks, Judge Byrd. And then the last question, could you describe what the Family and Children First Council is? Jeff, if you back in half a second or less, is that possible?
Locally operated councils. It's a of community partners involving education, the justice system, the developmental disabilities. It's kind of all of the community partners locally. In Ohio, they have embedded in statute a mechanism for them to meet and to discuss multi-system youth issues, and then to come up with local solutions to address those issues. So it's to assist in the coordination of care for youth locally.
All right, thank you, Jeff. So I know we're a little over time here, but I just want to take just the last few points just to say thank you to all of you who joined us for the webinar this afternoon, and definitely to our presenters for an excellent presentation. Thank you. So we have another webinar, third webinar, the 2016 webinar series that's scheduled for August 31st from 3 to 4 p.m. Eastern, and this webinar will focus on community schools, rural areas. And then the fourth and final webinar in the 2016 Rural Behavioral Webinar Series will focus on addressing maternal and child health. taking a rural perspective, and that will be conducted on September 7th from 3 to 30 p.m. Eastern. So please mark your calendars. Join us for these upcoming webinars. You can also get additional information about these webinars from the Rural Behavioral Health Webinar portal. And the address for that is also on the screen in front of you. And so before we part, I'd ask you, please, if you could take a few minutes to complete the participant feedback using the link listed on the slide that is in front of you. Really value your feedback and use the information gathered to enhance future webinar presentations. So once again, I just say on behalf of my colleagues here at SAMHSA, on behalf of our presenters and my colleagues at the American Institute for Research and Affirmative Solutions, thank you all for joining us this afternoon again, and look forward to seeing or hearing of you on the upcoming webinars. Thanks again. Bye now.
All right. Thank you.
That concludes today's conference. All participants may disconnect. Thank you for your participation.